Hello and welcome back to another video, continuing on in our series of AV heart blocks. Today we are talking about a second degree heart block, and this time we're talking about the MOBITZ type 2 rather than the type 1. So MOBITZ type 2, essentially what we're seeing here is, the best way to think of a MOBITZ type 2, first and foremost, think of this like a first degree block, okay? Think of it like a first degree block. And if you remember a first degree block, the classic gold nugget standard of first degree block is just consistent prolonged, prolonged PR intervals, okay? So think of it like a first degree block, right? But this time we have a drop. We have a QRS drop. So the first thing that we're going to see is basically these P waves, you'll notice, are more frequent than our QRS complexes. So why is this? Well, it's because of these drops, right? So obviously, if you were to take some calipers and you were to line up basically looking at this rhythm, you would see that for the most part, the atrial rhythm, right? So all your P waves, atrial firing off, are going to be normal and regular, right? Now your ventricles firing off, right? Your QRS complex, your R waves here, those typically will be slower and regular, or it could be irregular, it just kind of depends. But usually they'll be somewhat widened, right? Which we can kind of see here if you look. Now, as far as the P to QRS relationship, right? So the PR interval may be normal or prolonged, but it is constant until one P wave is not conducted to the ventricles, right? So that sounds very similar to a first degree in the sense that this PR interval is constant, right? Until there's just one P wave it's not conducted right. So it usually will occur at the level of the bundle branches, right? Now this guy is not good, okay? A MOBITZ type 2 usually progresses into a third degree, which is the worst type, okay? Now, if there's a certain number of impulses from the SA'd node that are not conducted to the ventricles, then the more frequent those impulses are not conducted, the more serious this becomes, right? So just some different causes that I have listed here. Could be, post-acute interior ACS, coronary syndrome. Could be a coronary artery disease, right? It's rheumatic heart disease. Or it could be drug toxicity, right? And due to delay or damage in the bundle branches, right? So you will notice, right, the patient, their manifestation, they're going to come in presenting, with decreased cardiac output, low blood pressure here. And again, just to recap, this is more serious than a type 1 second degree Winky Bach, okay? So for this, right, this needs a temporary pacemaker. Need one until a permanent one is placed, right? If you do have this block, though, it is an indication for a permanent pacemaker placement. So that is something that we're going to be weary of as we go forward. And if your patient presents with this, you know that they're going to need pacing.